Hello everyone, my name is Dr. Srinath Satyanarayana. I work as Deputy Director at the Center for Operational Research for the Union. Welcome to session 2 on the management of latent tuberculosis infection. In this session, we will discuss about TB preventive treatment, which we initiated in the first session. Just to give you an overview of TB preventive treatment, this is done to reduce the risk of progression from latent TB infection to active TB disease by killing replicating mycobacteria in the body. This reduces morbidity, mortality and transmission. 1 or 2 antibiotics that are effective against tuberculosis bacteria are used. The efficacy of TPT is said to be approximately 60%. A TPT assumes development of acquired drug resistance is unlikely given the small number of viable bacteria present in latent TB infection, and that is the reason only 1 or 2 antibiotics are used. Regarding populations eligible for TPT, so there are certain high risk groups which I said earlier are targeted for the provision of TPT, and we will discuss about those populations now. First population subgroup is people living with HIV after ruling out active TB. So, all adults and adolescents with HIV are eligible to receive TPT. Infants aged less than 12 months with HIV who are in contact with a person with tuberculosis is eligible. Children aged greater than 12 months with HIV, if they live in a setting with high TB transmission, then they need to be provided TPT. All children with HIV who have successfully completed treatment for TB disease, they are also eligible for the tuberculosis preventive treatment. One of the things that we have to note is that latent TB infection tests, IGRA tests or tuberculin skin tests are not required prior to initiation of TPT for people living with HIV. Now, the second population subgroup who are eligible for TPT are household contacts regardless of HIV status. The reason being that these are another group of people who are at very high risk of development of TB disease, and therefore, TB preventive treatment is recommended in them. So, when we look at household contacts, we generally divide them into children aged less than 5 years and children aged greater than 5 years, adolescents and adults. In children aged less than 5 years, no need for TB infection test, TPT can be given to children without TB infection test. Whereas, in children aged greater than 5 years, adolescents and adults, latent TB infection tests may be conducted if available and TPT given only to those who are LTBI test positive. But in case if LTBI tests are not available, then all children aged greater than 5 years, adolescent and adults can be given TPT. The next population subgroup who are eligible for TB preventive treatment are other at risk people. These are people who are on tumor necrosis factor alpha treatment, who are receiving dialysis, people who are undergoing or who have undergone organ or hematological transplant, and people with silicosis. In these individuals, LTBI tests may be conducted if available and TPT given only to those who are LTBI test positive, but in case if LTBI tests are not available in the setting, then these people can also be given TPT without LTBI test. There are certain other situations or in other settings where other risk people can be provided with TB preventive treatment. For example, in some countries, prisoners, health workers, migrants from countries with higher TB burden, homeless people and drug users are also populations considered for eligible for TB preventive treatment, whereas in our country this is not the case. And TPT is currently not recommended for people with diabetes, alcoholic, tobacco smokers and underweight people, even though they are at high risk of development of TB disease. But if these individuals, people with diabetes, alcohol, tobacco smokers and underweight people, if they have one of the above mentioned conditions, that is if they are people living with HIV or if they have household contacts of tuberculosis patients or if they come into other at risk population, if they are on anti-tumor necrosis factor treatment, receiving dialysis, organ or hematological transplant or silicosis, then these individuals are also eligible to receive TPT. But just standalone diabetes, alcohol, tobacco smokers and underweight people need not receive TPT even though they are at high risk. Now, what are the options that are available for TB preventive treatment? There are 5 options that are available, treatment options. These are 6-month regimen of daily isoniazid, which we also call as 6H, 3-month regimen of weekly isoniazid plus rifampicin, which we call as 3HP, 3-month regimen of daily isoniazid plus rifampicin, which is called 3HR regimen, 1-month regimen of daily rifampicin plus isoniazid 1HP, and 4-month regimen of daily rifampicin, which is called as 4R regimen. Now, of these, the first two options are the ones that are most popular, that is the 6H regimen and the 3HP regimen. In settings with high TB transmission, there is one more regimen that is recommended for people with HIV, adults and adolescents with HIV who have an unknown or a positive TB infection test, who are living in settings with high TB transmission. They are eligible for receipt of 36 months of isoniazid therapy, that is 36H, irrespective of the degree of immunosuppression, ERT status, history of previous TB treatment and pregnancy. So, these are the 5 plus this one additional are the TPT options that are available. Now, regarding algorithm for TB screening and TPT that is used in India, this is an integrated algorithm and the approach is the same in all populations eligible for TPT. First is we identify the target population, rule out TB disease, assess for contraindications for TPT, and if there are no contraindications, then provide TPT and ensure TPT completion. Now, let us look at the HIV positive individuals. What is the first step? The first step is to assess that they do not have tuberculosis. So, any symptom of current cough or fever or weight loss or night sweats, individuals are assessed for that. These are called the 4 symptoms. If they do not have any of these symptoms, then the next step is to assess if TPT is contraindicated in them, and in case if TPT is not contraindicated, then give TPT. If they have these symptoms, then they have to be investigated for active TB disease and they can be assessed for TPT contraindications if they have no active TB disease, but otherwise they will have to be investigated for TB disease. Now, similarly, among household contacts, first thing is we do a symptom screening, and if the symptoms are present, then they have to be investigated for active TB disease, and if the symptoms are not there, then if they are less than 5 years, as I said earlier, there is no need for an IGRA or a TST test. They can be directly assessed for TPT eligibility by assessing if they have any contraindications. If they do not have any contraindications, then they can be given TPT. In case if there are household contacts aged 5 years and above, then TST or IGRA test, if it is available, that can be done. If TST is positive or available, then we assess them for TPT contraindications, and if there are no TPT contraindications, then given TPT. If TST or IGRA is negative, then nothing, they need not be given TPT. And similarly, if the TST is positive or unavailable, then we can also do a chest X-ray screening, and those with abnormal chest X-ray will have to be investigated for active TB disease, and then TB disease has to be ruled out. In case if the chest X-ray is normal or unavailable, then they can be assessed for TPT eligibility by ruling out any contraindications, and then they can be given TPT. But whatever is done, whether TPT is given or TPT is not given, it is necessary to follow up all the individuals for active TB, because TPT, as I said, has an efficacy of approximately about 60%. So, even those who are given TPT can develop TB disease, and therefore, it is important for us to identify the TB disease early, and therefore, regular follow up not just for treatment adherence, TPT treatment adherence, but also for the development of TB disease is necessary for all those who are given TPT or who are also not given TPT. Now, regarding contraindications for TPT, there are certain contraindications which we have to be aware of. One is, as I said earlier, active TB disease, or when active TB disease cannot be ruled out, and this is a contraindication for TPT. Acute or chronic hepatitis, this is a contraindication for TPT. Concurrent use of hepatotoxic drug medications, this is a contraindication. Alcohol consumption, peripheral neuropathy, hypersensitivity to any of the drugs being considered for TPT. If there is hypersensitivity history, then these are contraindications. Pregnancy or a previous history of TB are not contraindicated for TPT, and people with these two conditions can be given TPT safely if they are eligible. Now, comparison of TPT options, as I said, 6H, that is 6 months of isoniazid, and 3HP, which is 3 months of weekly isoniazid and rifampicin, are the most popular ones, and let us discuss and compare these two options. Now, the medicines that are used are isoniazid, whereas here in 3HP the medicine that is used is isoniazid and rifampicin. The duration is 6 months here, the duration is 3 months here, the interval is daily, it is given daily, whereas here it is weekly. The doses are 182 doses, 6 months, daily 182 doses, whereas here weekly 3 months, and therefore 12 doses. The pill burden per dose is 1 pill, whereas here an average adult can receive up to 9 pills with loose drugs. So, 108 pills is the use. So, one of the issues with 3-HP regimen, even though it is a weekly regimen, is the high pill burden. Then pregnant woman, it is safe for use. Here the safety is not known, therefore, it has to be used very cautiously. Interactions with antiretroviral therapy, this is for people who are PL-HIV, that is people living with HIV who are receiving antiretroviral therapy. Here 6-HP, all the drugs that are used in antiretroviral therapy can be used, whereas 3-HP regimen is contraindicated with certain PIs, NVP and NNRTIs and TAF, and it can be used safely with certain drugs like TDF, EFV, DTG and RAL without dose adjustment. The toxicity, hepatotoxicity is more here, and this is one of the most important side effect that individuals can develop, and therefore, there is a need to monitor the liver enzymes, and once the liver enzymes are elevated 3 times or more, then the isoniazid will have to be stopped, and this is one of the most severe complication that can happen when TPT is given, and therefore, we have to be cautious when using TPT because of this. Now, the chances of hepatotoxicity are much more in individuals who receive 6H, whereas the chances of hepatotoxicity are less, but and also the occurrence of side effects is relatively mild and less with the 3-HP regimen. Now, regarding absorption, it is best absorbed in an empty stomach, but up to 50% reduction can happen if it is consumed with a fatty meal. Oral rifampicin bioavailability is 70%, the peak concentration is increased if it is taken within a meal. Now, regarding the dosages, here again we have to take age as well as the body weight into consideration when determining the dosage. For 6H regimen, that is 6 months of daily isoniazid, if the age is 10 years or older, then 5 milligrams per kg body weight can be given. If age is less than 10 years, then 10 milligrams per kg body weight can be given. So, the range is 7 to 15 milligrams. 3 months of weekly rifampicin and isoniazid, that is 12 doses, 3-HP regimen, depending upon the age less than 2 years, this 3-HP regimen is currently not recommended, and it is given only to those aged 2 to 14 years and age greater than 14 years. In 2 to 14 years, then the body weight, according to the body weight, 10 to 15 kgs, 16 to 23 kgs, 24 to 30 kgs, 31 to 34 kgs and greater than 30 kgs. These are the drugs that are available, isoniazid 100 milligrams and rifampicin 150 milligrams when they are in loose tablets, and depending upon the body weight, here you can look at the number of drugs that needs to be given. And isoniazid and rifampicin is also available as a fixed dose combination in 150 milligrams and 150 milligrams. Now, when these fixed dose combinations are available, then according to the body weight, we can give the number of pills as given here. Now, in those aged greater than 14 years, again isoniazid here 100 milligram tablet is there, here we can use a 300 milligram tablet. Rifampicin is the same, which is 150 milligram tablet. Therefore, when loose tablets are used, then we will have to divide them into 5 body weight categories, and 30 to 35 kgs, 36 to 45, 46 to 55, 56 to 70 and 70 kgs and above, and depending upon that, as you can see, the drugs can be given. And isoniazid and rifampicin as fixed dose combination is also available as 300 milligrams and 300 milligrams of isoniazid and 300 milligrams of rifampicin, and these can be used. Now, regarding the administration of pyridoxine. Now, certain individuals are at high risk of peripheral neuropathy, and therefore, whenever a TPT is given to them, pyridoxine needs to be added into their treatment schedule. So, these are individuals with malnutrition, chronic alcohol dependence, HIV infection, renal failure or diabetes, pregnant or breastfeeding women. So, these people are at high risk of development of peripheral neuropathy, and therefore, pyridoxine has to be used. The dosage of pyridoxine is 10 milligrams per day in children, 25 milligrams per day in adults, and adult PL-HIV the dose would be 50 milligrams per day. Now, let us move on to the next session. So far we have covered whatever we have discussed. These are TPT for contacts of drug sensitive TB. Now, TPT for contacts of MDR-TB. Preventive treatment may be considered based on the individualized risk assessment and sound clinical justification. The drugs that have to be chosen is according to the drug susceptibility profile of the source case, and the confirmation of infection with latent TB infection may be considered necessary here because of the complications involved in providing TPT and choosing the drugs for contacts of MDR-TB, and close monitoring for adverse events and adherence to treatment is recommended. Now, the algorithm for contacts of MDR-TB with fluoroquinolone sensitive or a H resistant with R sensitive bacteriologically confirmed pulmonary TB DR-TB patient. So, the principles are the same: identify the population, rule out TB disease, assess for contraindications for TPT, and if there are no contraindications, then provide TPT and follow up for TPT completion after they have been initiated on TPT, and in case if they have not been initiated on TPT or if they have been initiated on TPT, the patients have to be regularly followed up for the occurrence of TB disease. Now, for regarding the TPT options in contacts of drug resistant TB, there are two options. One is 6 months of daily levofloxacin for contacts of rifampicin resistant but fluoroquinolone sensitive patients, and the second one is 4 months of rifampicin daily regimen for contacts of H resistant, that is isoniazid resistant but rifampicin sensitive patients. Again, the dosage and weight band are as follows: age greater than or equal to 15 years, by body weight, less than 45 kgs 750 milligrams once daily, greater than 45 kgs 1 gram per day. Age less than 15 years, the dosage range is approximately 15 to 20 milligrams per kg per day by body weight. So, those with 5 to 9 kg can be given 150 milligrams per day, those with 10 to 15 kg can be given 200 to 300 milligrams per day, and those weighing 16 to 23 kgs can be given 300 to 400 milligrams per day, and 24 to 34 kgs can be given 500 to 750 milligrams per day. Regarding 4R regimen, which is given to contacts of isoniazid resistant rifampicin sensitive patients, age 10 years or older 10 milligrams per kg body weight, age less than 10 years 15 milligrams per kg body weight, and the range for these children is 10 to 20 milligrams per kg body weight per day. Now, before concluding, the key messages are that management of latent TB infection is essential to achieve WHO NTB strategy goals. Either TST or IGRA can be used to detect LTBI, but both cannot be used to diagnose active TB disease. Then TB preventive treatment reduces the risk of progression from LTBI to active TB disease, and therefore, it is always recommended for individuals who are to be given this drug. And prior to starting TPT, it is essential to rule out TB disease and any TPT contraindications, and only in those without contraindications or without TB disease should be given TPT. And after starting TPT, it is essential to follow up individuals for the development of TB disease, because TPT is not 100% effective in preventing TB disease, and therefore, individuals have to be followed up for TB disease. Then those who are started also need to be followed up for side effects of TPT and to ensure TPT conclusion. So, with this we come to the end of this lecture on management of latent TB infection. I hope you gained some insights into the basics of latent TB infection as well as the TB preventive treatment. For further details, please feel free to read these documents, which I strongly recommend you to do so. These are the WHO consolidated guidelines on tuberculosis, WHO operational handbook on tuberculosis, and then our own national TB elimination programs, guidelines for programmatic management of TB preventive treatment in India. So, thank you.